Welcome to Pathology Central Key Concepts. The topic of this video is autoimmune thyroid disease. So I'm going to begin with a brief overview of thyroid physiology, followed by a discussion of the laboratory tests that we use in the diagnosis of thyroid disease. And then I'm going to work through each of the different entities that we consider in the context of autoimmune thyroid disease. So first, that brief overview. So as you recall, when the body is in need of thyroid hormone, the hypothalamus is going to release thyrotropin-releasing hormone, or TRH, which will stimulate the pituitary gland to produce thyroid-stimulating hormone, or TSH. TSH is going to bind to the TSH receptor in the follicular epithelium of the thyroid. This is a G protein coupled receptor, and through this pathway, we're going to get an increase in the second messenger cyclic AMP. And with this, we're going to get signaling pathways that will cause the production of T3 and T4, which will then be released into the blood. Now, before we follow the pathway of T3 and T4, let's look at this side of the equation, which is if you have abundant T3 and T4, we're going to get negative feedback inhibition on the pituitary gland, no need for TSH, as well as on the hypothalamus, no need for TRH. And it's important to understand this because as we look at the laboratory tests, this will help you understand why we see the different values that we see. All right, coming back to our little world here where the T3 and T4 have been released into the blood. They don't just float around free, they are immediately bound up to plasma proteins. Only a small amount is actually free in the blood. And these plasma proteins are thyroxine binding protein, transthyretin, among others. Now, in the periphery, most of the free T4 will be deiodinated to T3, and T3 is about 10 times the activity of T4. When T3 and T4 enter the cell, they're going to bind to the thyroid hormone receptor, which will bind to response elements on the DNA, causing transcription of target genes. Now, these proteins have a variety of different effects, but the end result is going to be an increase in the basal metabolic rate. Okay, so how do we assess a patient when we are considering the possibility of thyroid disease? Your number one first test you're going to look at is thyroid stimulating hormone, so TSH, also known as thyrotropin. So we will use this as a screening test for both hypo and hyperthyroidism. Now, the next test that you'll consider if your TSH is abnormal is looking at free and total T4, thyroxine. These two tests are used together to try to understand whether it's a primary or a secondary thyroid disease. Now, total T3 is not used as commonly. It's used to assess hyperthyroidism, to see the extent of hyperthyroidism, but not so much in hypothyroidism because a patient may have normal total T3, but atypical values for TSH and free and total T4, because total T3 may be the last value to change in hypothyroidism. So let's look at these tests and how they are useful. So you have a patient who's presenting, you think perhaps this patient is hypothyroid. The first screening test you're going to do is a TSH. If you see an elevated TSH, but the patient is presenting as hypothyroid, and you do the next test, which shows you that you have low T4, then you know that this is a primary hypothyroidism due to thyroid disease. How do we know this? Okay, so we know we have hypothyroidism because we have low T4. What T4 is supposed to do when it's low is to stimulate the hypothalamus to release TRH and then increase TSH. So we have lots of TSH. So TSH is saying, yes, yes, make T4. And the thyroid is saying, no, I'm not going to do it. So this tells you that the pituitary axis is working fine, that it's the thyroid that has some problem with making T4. Now, say you think this patient is hypothyroid and you do your TSH and you see that TSH levels are low. What this is telling you is that here we have low T4, which is saying to the hypothalamus, make TRH, and it's saying to the pituitary gland, make TSH, and the pituitary gland is this time saying, yeah, no, I'm not going to. So now we know that in the setting of low thyroid hormone, the pituitary is not making TSH. This suggests that we have a problem with our pituitary gland. Now, if you have a patient who you think is hyperthyroid, you're going to look at this patient. They're going to come in maybe with palpitations, feeling it with flushed skin, heat intolerance, and you do their test and you see they have low TSH. And then you will do their T4 and you'll see, yes, they have elevated T4. So we know that they are hyperthyroid. The low TSH is because when you're replete with T4, once again, it's telling the hypothalamus, no, we don't need TRH, telling the pituitary, no, we don't need TSH. So this is going to be a problem, again, of the thyroid. All right, these are the 5 diseases that we consider in the context of autoimmune thyroid disease. We really typically consider these 4 separately and focus on Graves' disease as a special entity, primarily because this one we really think about as hyperthyroid. So if you have a patient with hyperthyroidism, you're really going to be concerned about Graves' disease. Now, these are more commonly going to be hypothyroid, or in the case of Riedel Thyroiditis, euthyroid. Although they can have some transient thyrotoxicosis, which I'll talk about in a moment. Okay, so this is just a nice compare and contrast of those first 4 entities. So you might want to take a screenshot and use this for studying. I'm not going to work through each of these because I know that you can work through it on your own. But I do want to make a couple of points. One is to recognize that for all of these diseases, they are more common in females than in males. The other thing that I want to point out are some of the clinical features. Okay, so Hashimoto thyroiditis, we typically think of as being progressive hypothyroidism, but as I'll mention, you may have a temporary transient hyperthyroidism at the outset. The Quervain or subacute granulomatous thyroiditis also can present with some hyperthyroidism before moving to hypothyroid, or can show both. And this is most commonly associated with neck pain. And that contrasts with painless thyroiditis, which is a painless neck mass. Again, can begin with a little hyperthyroidism, may go directly from that to resolution, or may progress to hypothyroidism. Again, it may resolve, or the patient may remain hypothyroid. And then in Riedel thyroiditis, the clinical here is particularly important because it can mimic an invasive thyroid carcinoma. When thyroid carcinomas progress out of the thyroid and invade the soft tissues of the neck, they can become hard and fixed, which is what we also see in Riedel thyroiditis. These patients tend to be euthyroid, so neither hyperthyroid nor hypothyroid. All right, let's begin with chronic lymphocytic or Hashimoto thyroiditis. This is the most common cause of hypothyroidism where iodine is sufficient. As you recall, we need iodine to make our thyroid hormone. And if you're working in an area where iodine deficiency is endemic, so this is typically going to be very high mountains isolated from the coast because we get most of our iodine from the ocean. In these situations, the hypothyroidism may be due to iodine deficiency, but because of iodine supplementation of salt, for most of the world, we do not see this due to iodine deficiency. Patients will present with a painless enlargement of the thyroid and gradual hypothyroidism. Now, they may present with a transient thyrotoxicosis at the outset, and the reason is that Hashimoto thyroiditis is due to an autoimmune attack on the thyroid, and when that happens, you can get release of colloid and release of free T3 and T4, which will be increased in the blood. Now, this can be that transient hyperthyroidism. As T3 and T4 levels go up, you're going to have negative feedback inhibition on the hypothalamus and the pituitary, leading to a decrease in TSH. However, with continued attack and destruction of the thyroid follicles, you're going to get decreases in T3 and T4, and the hypothalamus is going to say, oh, we need more, put out TRH, and the pituitary is going to say, we need more, put out TSH, but we won't be able to respond. So why can't we respond? It's because we've had an attack on our thyroid epithelial cells. So the pathogenesis is an autoimmune response against thyroid antigens. These are the 2 main avenues by which we get this destruction. I have this here in italics because you may see this in older texts. We used to consider this as being one of the potential causes of Hashimoto thyroiditis because for a couple of reasons. One is that was what we saw in animal models, and also because most patients with Hashimoto thyroiditis will have anti-thyroglobulin and anti-thyroid peroxidase antibodies. We no longer consider this to be a primary contribution to Hashimoto thyroiditis. It's likely that these antibodies build up because of release of colloid and an immune response to that. Okay, so what causes Hashimoto thyroiditis? We have CD8 positive T cells that are going to directly attack the thyroid epithelial cells, and we will have activated CD4 positive T cells that are going to release inflammatory cytokines like interferon gamma, which will recruit and activate macrophages, causing direct follicle damage. So here's an image from Robbins and Kumar, Basic Pathology, 11th edition. Here we have our happy, healthy thyroid epithelium, but somehow we get a breakdown in self-tolerance and induction of thyroid autoimmunity, which is going to cause these CD8 positive cytotoxic T cells to recognize these thyroid epithelial cells, these thyrocytes, not as self, but as non-self. And so there's going to be direct killing and thyrocyte injury. CD4 positive Th1 cells will begin releasing interferon gamma, which will recruit and activate macrophages, again, which will be attacking the thyrocytes. All right, so what does this look like morphologically? The patient will typically present with a thyroid neck mass. So you'll see a central mass here in the neck. Microscopically, we'll see a mononuclear infiltrate of inflammatory cells, well-developed germinal centers, and then this attack on the thyroid epithelium is going to lead to atrophic thyroid follicles. And there's a metaplastic change that we can see in thyroid epithelium, which is called Hürthle cell change, and these are called Hürthle cells, which have abundant eosinophilic granular cytoplasm. So let's take a look here. I've got a little inset with a normal, healthy, happy thyroid here, where you can see abundant colloid and flat, small follicular epithelial cells. By contrast, here in this image, we see first a well-formed germinal center, a lot of mononuclear cells infiltrating, and then we have somewhat atrophic follicular cells and follicles. So not abundant colloid. The cells are perhaps a little bit enlarged. They're unhappy. They're being attacked. Now here's an image showing Hürthle cell change. Again, normal thyroid here for comparison. Look how large and fluffy these cells are. Abundant cytoplasm, very eosinophilic, and somewhat granular. So this is Hürthle cell change. Now, as you'd imagine, when you have all of these inflammatory cells in this organ, just as we've seen in other organs like in Helicobacter pylori gastritis, where you can get a malt lymphoma, or in Sjogren's syndrome, where you can get a marginal B-zone lymphoma that forms. We can also see that in Hashimoto thyroiditis. So patients with Hashimoto thyroiditis are at increased risk for other autoimmune diseases like type 1 diabetes, systemic lupus erythematosus, myasthenia gravis, and Sjogren's syndrome. But also because of these sheets of reactive B cells, you can get an extranodal marginal zone B cell lymphoma. And that's what we see here is just such a lymphoma arising in a background of Hashimoto thyroiditis. So this low power view is remarkable for just the sheets of cells that we see here. On higher magnification, you can see these sheets of B cells. And then there's just a little bit of residual follicular epithelium here. And we know they're B cells by doing an immunohistochemical stain. Okay, so this brings us to our next entity, which is subacute granulomatous, also known as de Quervain thyroiditis. And this is an uncommon entity. And the pathogenesis is associated with some sort of upper respiratory tract infection. So most patients will have a URI shortly before onset. And it's thought that this is either that de Quervain thyroiditis is either caused directly by the viral infection or an inflammatory response to viral infection. And it typically will resolve spontaneously. This is one of the reasons that we don't see this particularly commonly. Perhaps it resolves before the patient comes to care. So morphologically, we're going to have a firm, enlarged thyroid, which may be unilateral or bilateral, unlike what we see in Hashimoto or in Graves' disease, which are bilateral. And microscopically, we're going to see mixed inflammation, but as the follicles are destroyed and disrupted, that colloid is released, and we're going to get a granulomatous response to that foreign body. So let's take a look here. This is just a beautiful example of granulomatous thyroiditis. You can see the typical thyroid follicles here with abundant colloid, but there is this mixed inflammation trickling through, and then here we have a granuloma formation. And if you look closely, you can see there's a little bit of colloid here. These multinucleated giant cells are consuming and walling that off. So this is that classic appearance that we see in this entity. Okay, our next entity is something called subacute lymphocytic thyroiditis. It's also called painless thyroiditis, and that's remarkable because it is painless. We don't know as much about this particular type of thyroiditis, although that it is thought to be autoimmune, and we see antithyroid antibodies in most patients. Now, there is a subtype of this that can present postpartum in up to 5% of women, and so that's something else to consider in that clinical setting. Patients will have a mild thyroid enlargement, which, as I mentioned, is painless, and microscopically we see a lymphocytic infiltrate in germinal centers. And despite looking in multiple sources, I couldn't find material or a micrograph of this. So we'll just know that this is what it looks like, and you'll be able to think about this if you see it on board exams, etc., by the clinical context. All right, this brings us to our final of the 4 entities, Riedel Thyroiditis, and this is an uncommon disease, and it's one of the IgG4 related diseases, which, as you'll recall, are associated with increased numbers of IgG4 cells, and abundant fibrosis. So there are a number of entities that are associated with IgG4. What we'll see, as I mentioned earlier, is this hard, fixed thyroid mass that's adherent to the surrounding tissues, and this mimics malignancy. So you might be thinking that your patient has a malignant thyroid tumor. Microscopically, we'll see this abundant fibrosis that's almost keloidal, just thick collagen bands, and a marked lymphoplasmacytic infiltrate. So we can see that here. We have these thick collagen bands, and then just a little bit of thyroid epithelium left. And this fibrosis will extend into the tissue, the soft tissue around the thyroid, mimicking that invasive carcinoma. And then this is an immunohistochemical stain for IgG4, and you can see that there are increased numbers of those in this background. Okay, this brings us now to our final disease to consider. This is the one we think about with hyperthyroidism. So if you have a patient who's presenting with symptoms of hyperthyroidism, so weight loss, heat intolerance, sweating, flushing, very active, you'll be thinking about Graves' disease. And the features that we see here are going to be hyperthyroidism with diffuse thyroid enlargement, a very classic and characteristic infiltrative ophthalmopathy, and an infiltrative dermopathy, which is a myxedema due to glycosaminoglycans frequently seen in the pretibial region. Now, the pathogenesis of Graves' disease is an autoimmune response against multiple thyroid antigens, and the most important of these is the TSH receptor. So about 90% of patients will have an antibody we call thyroid-stimulating immunoglobulin because it binds to the TSH receptor and stimulates. And what happens is once we get our increase in our cyclic AMP, we get release of our thyroid hormones, free T3 and T4 levels will go up. Because of negative feedback inhibition, TSH levels will go down, right? So if you have a patient and you do your TSH, they're presenting as if they're hyperthyroid, low TSH, and then you see that the T4 levels are high, then you'll be thinking about Graves' disease. Now, the thing to keep in mind is that there can be multiple thyroid antigens that are involved. So less commonly, we will see thyroid blocking antibodies, and this can lead to hypothyroidism. So this can explain to some extent the clinical course of Graves' disease. There may be episodes of hypothyroidism. So this is the classical exophthalmos that we see in hyperthyroidism. The bulging protrusion of the eyes is due to pushing forward because of soft tissue behind the eyeball. And that's going to be both due to hypertrophy of muscles, well, not so much hypertrophy of muscles, but growth of the muscles, swelling of the muscles due to a mononuclear cell infiltrate, inflammation and edema from the inflammation. We're also going to get increased fibroblast proliferation due to cytokines secreted by CD4 positive T cells. So we're going to get fibroblastic proliferation and synthesis of glycosaminoglycans. Now, as you recall, glycosaminoglycans are very hydrophilic. That's going to bring in that fluid, which is going to cause this edema. We also can get a fatty infiltrate. So here we see just a nice CT scan, and you can see just how large our orbital muscles are. And it can be difficult to appreciate, so go ahead and do a screenshot and then do a higher magnification. There are 2 little arrows here to help you find it. But you'll notice that the extraocular muscle here is not homogeneous. If you look here, they're quite homogeneous. There's a dark area of signal. That's due to fatty infiltrate of the muscle, which again is going to cause it to increase in size. And here we see our medial rectus muscle, which is quite large, much larger than it should be, because of inflammation and edema, which is causing that, and that is going to be pushing the orbit forward. So what do we see morphologically regarding the thyroid is we're going to see this diffusely enlarged thyroid. And microscopically, we're going to see these tall, crowded epithelial cells. So remember, the thyrocytes are receiving what they think is a signal to start generating T3 and T4. And they're being told to do it very quickly and get it out. So they're going to be very activated and hyperplastic, which can form small papillae. These will differ from the papillary formation in papillary thyroid carcinoma by lacking a fibrovascular core. And I'll do a compare and contrast for you of that in a moment. Now, as we're generating as much T3 and T4 as we can, we're going to be sucking out of the colloid. So it's going to be pale and it's going to be scalloped as the thyrocytes are consuming the colloid. We'll see lymphocytes, T cells, and some plasma cells. And again, we can see germinal centers. I'm not going to show you those because they're not quite as... They're quite similar to what we see in the other diseases. I'm going to focus here on just like the really classic findings. So here you see this just really beefy, bulging, enlarged thyroid gland. It's fairly homogeneous, and you can see that it has this glistening appearance. Here's what we see microscopically. As I mentioned, the thyroid is a little bit pale, and these classic scallops, right? Because these thyrocytes are consuming as much colloid as they can to generate T3 and T4 because their TSH receptor is signaling wildly. And they can form these little papillations. And I just want you to be aware, if you see this on an exam somewhere, not to confuse this with a thyroid papillary carcinoma. Here's a little compare and contrast for you. These are the papillary structures, much more complex, that you see in papillary thyroid carcinoma. We don't really see much colloid at all. And just keep in mind the nuclear features of papillary thyroid carcinoma will be nuclear clearing. You can see a little bit here, sometimes some nuclear folds. All right, I'm going to end, as always, with some questions for you to reflect on what you've learned in the last 20 minutes or so. I hope you find this helpful. As always, thank you very much for your time. Please let me know what you like about this, if this is working for you, and follow me on Twitter. Check out my website. So thank you very much.